The video series Better Disease Management was developed by the Georgia and Oklahoma Academies of Family Physicians as a part of the Go Diabetes Initiative. The Better Disease Management series consists of 7 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for participating in this online activity and hope that it serves as a valuable educational tool.
There was a landmark study called the United Kingdom Prospective Diabetes Study that you all probably have heard of. It took place, as you can tell from the name, in the United Kingdom, but this was in type 2 diabetics. You know, we found out that glycemic control mattered in type 1s, but in type 2s we still didn't quite know. It's a different disease. It has some similarities, has a lot of similarities, but it's also very different. The glycemic difference, and they had both a blood sugar control arm and they also had a blood pressure control arm. The differences achieved, you can see on the second or the first bullet point there where it says glycemic control. The difference in glycemic control was not very much. It was 7 in the people who were treated more intensively versus 7.9 in people who were treated less intensively. Blood pressure control, there was only about a 10-point reduction in systolic blood pressure, but nonetheless it was substantially different. The medications that they were using old medicines, some that you all still use and I use. Metformin, they were using sulfonylureas and they were using insulin. For blood pressure, they were using captopril, which probably you don't use and I don't use very much just because it has such a short half-life. And they also used atenolol. And the first slide I'm going to show you is something that does not deal with glycemic control, but it's with blood pressure control. Now remember, the differences here was only 10 points, okay, 154 versus 144. But look at the risk reduction. Look at the second one there. Diabetes-related deaths were down by 32% in the people who just had a blood pressure that was 10 points lower. Now you and I would think, well, a blood pressure of 144, we can do better than that. And we probably can. In the United Kingdom, there was a headline in a newspaper that said, 1 in 3 diabetes deaths preventable. And you know, often the media kind of sensationalizes things related to healthcare, but they're actually probably right about that. So what we really found out was that it's not just about blood sugar. Blood pressure plays a huge role, and lipids will play a huge role as well. The other thing that I think was interesting is that even the small vessel disease, the microvascular disease there at the very bottom, was reduced by 37% in people who had lower blood pressures. This is a slide that shows the differences that were achieved in blood sugar. And you can see when people were diagnosed, these were newly diagnosed type 2 diabetics, they all had A1Cs of about 7. The people who were managed intensively dropped their A1Cs down to about 6. The key thing that I'm going to show you here is that both groups worsened over time, okay? Even the people who were managed intensively. So you'll notice in your type 2 diabetic population, you'll have somebody who's controlled, who has their A1C less than 7. 3 years later, when you're a third-year resident, you'll say, gosh, what happened to you? And they're like, doctor, I swear, I'm taking my medicine, I'm walking, I'm trying to watch my diet. And you know, you'll shake your finger at them. But remember, this is actually, what happens is insulin production goes down. Every 5 years, your insulin production goes down by about 50%. And so that's the reason, that's one of the things that was identified from that study that's important. And as we talk more about additional therapies, we'll get more into that. There was really not much reduction seen in endpoints in the blood sugar control group. Now remember, the difference here was 7% A1C versus 7.9%. There was only a 12% reduction seen over 10 years. You had to treat 19 people for 10 years before you reduced one person developing nephropathy or retinopathy. Okay? The outcomes were not nearly as impressive as what was seen with blood pressure. And I think the subsequent studies that we're getting ready to discuss will kind of bear that out as well. There were some reduction in microvascular endpoints. They were reduced by about 25% in the people who were treated more intensively, and this were for basically eye and kidney disease. Well, after those two studies were done, as you know, we like to think, well, if a little's a good, well then a lot must be really good. And so that spawned 3 other large studies that have all come to an end, and we're going to talk about those briefly. I'm going to try to summarize these for you. You all have probably heard about some of these. You may not have heard about all of them. These all involved type 2 diabetics. They were the ADVANCE trial, the ACCORD trial, which has probably had more press than anything else in the United States, and then the Veterans Affairs trial, the VADT, the Veterans Affairs Diabetes trial, that's listed 3rd there. I'm going to show you the similarities between these studies. We're not going to go into detail about each one. The ADVANCE trial took place, type 2 diabetics who had been diabetic for a long time, probably about a decade. All the studies had been diabetic for at least a decade. People, most of them in their late 50s or 60s. A good majority of them had heart disease of some sort. And then they wanted to see if we lower blood sugar significantly, we get A1Cs down in the 6% range, do we reduce heart attack and stroke? The ADVANCE trial did not show that. If we lower blood sugar to near normal, did not appear to reduce cardiovascular events. There was a small reduction seen in microvascular disease in the ADVANCE trial. The ADVANCE trial did have a blood pressure lowering arm that used an ACE inhibitor called parandolopril and indapamide, a thiazide diuretic. It helped lower microvascular disease, but there really wasn't any reduction seen in macrovascular disease in this study. The ACCORD trial has had a lot of press, as I mentioned, mainly because they were taking, again, type 2 diabetics who had been diabetic for over a decade, had a high prevalence of heart disease within their group, and trying to take them from A1Cs of like 8.5 down to 6. And what they found is that the people that they tried to treat intensively seemed to die faster than people that were treated more normally. Okay, when I say more normally, A1Cs of about 7. Okay, and so there was a headline in the New York Times about 2 years ago that said diabetes study halted, and that was the blood sugar arm of the ACCORD trial. The ACCORD trial also had cholesterol or hyperlipidemia arm, and it also has a blood pressure arm that Dr. Baylor is going to be talking about a bit later as well. But that has the comment I made about actually showing an increase in the risk of dying by intensive treatment of blood sugar in these patients. That's been questioned a bit recently. There's been a meta-analysis that's called that into question, and we're not quite sure if that's actually the case. But on the other hand, it does come with the risk of low blood sugar and a lot of extra work on the part of patients and expense, and there wasn't any benefit for sure. So the old thing about lower is always better with your A1C, not true. Get them to 7 is still the take-home message, and not don't push them to get an A1C of when they come to you at 8.5 and get them to 6, unless they're doing it by diet and exercise and metformin, then you're probably fine. But I wouldn't put them on 3 or 4 medicines to do it. Veterans Affairs trial, it was a large trial as well. Involved type 2 diabetics and basically did not show any reduction with intensive treatment of blood sugar. So similar outcomes to what was seen. So here's the recommendations from the American Diabetes Association, the standards of care that exist currently. Most patients should target their A1C to be less than 7. I think there is good evidence for that. Now that may not be the case for everybody. For example, if you have an 80-year-old patient that has dementia, or a patient who has a limited life expectancy, say they've got peripheral vascular disease, they've got 3-vessel coronary artery disease, they have a creatinine of 2. Well, I'm not going to push to have that person's creatinine down to 7. That's somebody with a limited life expectancy. Another example, if I had somebody who was gestational diabetic, or excuse me, not a gestational diabetic, if I had somebody who was a type 1 diabetic who was trying to become pregnant, well, that's different. We're trying to trying to have a different outcome, particularly with first trimester control, and those people need A1Cs much lower than 7. Okay, so the take-home message from the ADA is that you need to establish your goal with your patient based on their circumstances, where they are in life, what they're able to do, what's the risk of having hypoglycemia with that individual, and make it flexible. General rule of thumb, 7% is a good number to shoot for. The other thing that's been shown, and this is, as I was talking earlier, blood pressure and lipid control pay just as big a dividends as blood sugar control, and probably bigger in type 2 diabetics. This is just a summary. I won't read all this to you, but these are things that you know. The one thing I will show you, the preprandial glucose. If you have a preprandial glucose or a fasting glucose in that 70 to 130 range, a large percentage of your patients are going to have A1Cs less than 7. And if you're having 2-hour postprandial glucoses of less than 180, most of your patients are going to have A1Cs of less than 7, and that's why those numbers are what they are. The other thing I'll tell you is that down on the next to the bottom line, the antiplatelet therapy, that's changed in the 2010 standards of care. The recommendations used to be everybody over the age of 40 should be placed on aspirin if they had diabetes. There's been evidence that that's not beneficial for everybody in that group. And so there's recommendations now that if you're over the age of 50 and you're a man, if you're over the age of 60, plus you have a risk factor, another risk factor, for example, hypertension, then those people should be on antiplatelet therapy like aspirin, okay? But your 35-year-old patient who's female, who is normotensive but is obese, and that patient probably does not need to be on aspirin.